So there's a video on optic neuritis, and today we're going to be talking about location, location, location. And normally in the past, we would say it really doesn't matter where the optic neuritis is. It's optic neuritis. The treatment is the same. Intravenous steroids makes you get better faster. Oral steroids in conventional doses not recommended. You should use high dose oral steroids if you're going to use it, and make sure you don't have MS. So that's going to be an MRI. And in the optic neuritis treatment trial, we only did MRI of the head, but now you need to do orbit plus the head with gadolinium and fat suppression, because the characteristic location, pattern, and length of the optic nerve enhancement does make a difference. And that's going to be the topic today: location, location, location. So the optic nerve has four pieces. It has an intraocular portion, which is the optic disc head. It has an intraorbital portion, which is in the orbit. And then as it passes through the bony canal, that is the intracanalicular portion, because it's in the optic canal. And then you have the intracranial portion. So the four pieces of the optic nerve: intraocular, intraorbital, intracanalicular, and intracranial. And normally, if you have just a short segment of intraorbital enhancement, that is the most common location for optic neuritis enhancement, but it can also be intracranial. And the thing you need to know is, if it's intracranial and going to the other side or at the chiasm, you really should be thinking about the MS mimics in that setting. So both longitudinally extensive enhancement, defined as greater than half the length of the optic nerve, or chiasmal or bilateral involvement, NMO, MOG, the usual suspects, sarcoid, syphilis, the other causes, once you get chiasmitis, because for whatever reason, MS likes to go right there. If it's just intraocular enhancement, that usually means the problem is in the eye. And so if the disc is swollen, the dye will leak out, because there's breakdown of the blood-retinal barrier and the blood-optic nerve barrier there. And so you should be testing this person for the intraocular types of inflammation in the eye, including infection, syphilis, cat scratch disease. So once the disc is swollen, that's the intraocular one. And that is very uncommon in demyelinating optic neuritis, because most cases of optic neuritis from MS are the doctor sees nothing, the patient sees nothing. There's nothing to see. It's a retrobulbar optic neuritis. So this optic disc edema is already a big red flag that it's not optic neuritis from MS. You should be working that up for the alternative etiologies, including NMO and MOG. And then that brings us to this piece right here, the intracanalicular piece, which is in the bony canal. And the reason that one's important is, if you have a little bit of edema here, and that edema is going to be seen on the T2 MRI, that's hyperintense signal intensity. The T2 edema, if it's in the canal, because the bony canal is a constricted space surrounded by bone, you're less likely to get a full recovery because of that, because there's going to be a compartment syndrome from the edema. So a little bit of edema in a bad location can lead to a bad outcome. And so if someone doesn't get full recovery, you'd like to look at this MRI and say, oh, no wonder they didn't get any better. It was intracanalicular edema. So for optic neuritis, in addition to all the other things you need to know location, location, location. Where was the enhancement? How much enhancement? Is it in the canal, which reduces your chance of full recovery, and is extending to the other side or the chiasm? That's atypical for demyelinating optic neuritis.